Otu. I'm one of the cardiac anesthesiologists. Good morning to those who I have not met yet. So this morning I'll be talking about the management of one of the rare but more potentially serious complications of our anesthetics, namely local anesthetic systemic toxicity. Next slide. So the objectives of this talk, first I'm going to define what is local anesthetic systemic toxicity, and I'll abbreviate it as LAST going forward. Secondly, we'll identify potential clinical situations where LAST may arise, and then last, we'll describe how we as anesthesiologists and support staff can help in managing this complication. So first, I wanted to start off by just talking about the use of regional anesthesia during pediatric surgeries. So this use has been increasing over the past couple years, mainly because we as anesthesiologists want to provide multimodal anesthesia. So what that means is a kind of a combination of pain relief for the pain. And typically because of the age of the patients and the fact that they're children, we use it as a supplement to general anesthesia rather than the primary anesthetic. And also, it's important to point out that we do the majority of these blocks under general anesthesia as opposed to adults, where we may do them in the holding area with the patients awake. So last, or again, the local anesthetic systemic toxicity, we'll talk about that first. So there are a couple papers recently have come out about LAST in children specifically, and they've estimated a rate of about 8 in 100,000 blocks that are performed. So this is actually less than the number that's quoted for adults. The number in adults is about 27 in 100,000 blocks. So as I mentioned in the beginning of this talk, it is a relatively rare complication, but it's potentially life-threatening, so it's one that we need to be paying attention for. So it results because of direct intravascular injection of our local anesthetic into either a vein or an artery, or if we use very large doses of local anesthetic, over time they can become systemically absorbed. And this will lead to excessive plasma concentrations of the local anesthetic, and then namely neurologic and cardiac complications. So this is a table that I took from one of my references, and it's just talked about some of the signs and symptoms that the patient may present with when they do develop toxicity from local anesthetics. So primarily the central nervous system is affected first. So the patients may complain of lightheadedness, they may complain of dizziness. They may say that they feel numbness or feel different sensations around their mouth. They may have visual or auditory disturbances, and then this can progress all the way to seizures and muscle twitching and tremors. With regards to the heart specifically, when there is local anesthetic toxicity, it primarily affects the rhythm of the heart, and then this can lead to cardiac arrest down the road. At low concentrations, the patients may have hypertension secondary to some vasoconstriction, and at higher concentrations, they may have vasodilation leading to lower blood pressures. And then finally, some of our medications, specifically one type of local anesthetic, can lead to ventricular fibrillation. So I'll talk a little bit more about that. This is a paper, again, talking about LAST in children specifically, which is our primary population. So again, as I mentioned, most of the patients have their block performed under general anesthesia, so they're not able to complain to us or tell us that they're, feeling numbness or anything like that. So actually in our patient population in children, they present primarily with cardiovascular presentations. So again, to review, they'll most likely have some sort of arrhythmia, or they may have cardiac arrest. But some patients may present with seizures or apnea under general anesthesia as well. So I'll talk a little bit about some of the risk factors for LAST. So there's 3 major categories which I'll go through. So one is the drug that we choose to use for our nerve blocks. Second is the patient characteristics specifically. And then third would be the type of regional anesthetic or the nerve block that we do. So first, starting off by talking about the choice of the local anesthetic. So primarily, you guys will see in the operating room, we're using ropivacaine, we may use chlorpropane or bupivacaine for the nerve blocks. So bupivacaine is one of the more potent lipid-soluble local anesthetics, and inherently, just by default, it has more inherent cardiovascular toxicity. So as I mentioned earlier, bupivacaine is one of those local anesthetics that if there is toxicity with it, it can lead to ventricular arrhythmias that are pretty resistant to standard therapy. And then cousins or relatives of bupivacaine, ropivacaine, and levobupivacaine are medications that are similar, but they have a safer cardiovascular toxicity profile. And so this graph on the right is just showing a study in dogs or a study in animals, but when there's a toxicity event, the rate of resuscitation versus the rate of death with all the certain local anesthetic medications. So you can see on the bottom with toxicity with lidocaine, about 100% of the subjects were resuscitated. There was a greater rate of death with bupivacaine, as I mentioned, because of its more potent nature. And then levobupivacaine and ropivacaine had higher rates of resuscitation. So this just goes to show the safety profile of some of the medications that we use. Here, I just added this as a reference. So this is a table showing the maximum doses or maximum safe doses of the common local anesthetics that we use. When they're used plain, we can use a lower dose, and when epinephrine is added, we can increase that dose. So sometimes when we're doing the blocks, depending on where we're doing them, we may choose to add epinephrine in order to increase the amount of dose that we're able to use. So next, I'll go on to the patient characteristics that lead to an increased risk for LAS. So within the pediatric population, there are certain high-risk patient populations. So that includes the neonates and infants, and primarily those infants that are less than 6 months of age. Former preemies also are at higher risk for developing LAS. And any patient that has either liver, kidney, cardiac, or metabolic dysfunction, again, also too, is at higher risk of developing LAS after a nerve block. And finally, patients that have low muscle mass, again, too, are considered within that high-risk population. This graph shows a spread of about 30 cases of LAS, and you can see, so it's broken down by age, and you can see the majority, or 17 of the 31 patients, were again infants. And then again, vast majority were under the age of 3. So this definitely reinforces the idea that our younger patients can be at higher risk for this complication. And then finally, I'll go on to the type of anesthetic and the regional anesthetic technique that we use. So increasingly, we're using continuous catheter techniques. So what that means is we'll do, single shot nerve block, and then we'll leave a catheter. For example, we do this in the cardiac patients who are undergoing a thoracotomy if we want to get initial pain control, and then we also want them to continue the pain control in the postoperative period. So as just by default, because we're giving continuous medications, there's the risk of that medication building up in the patient's system and leading to toxicity. Two, sometimes in the main OR, if we're doing certain procedures where 2 nerve blocks may be beneficial for the patient, we may do multiple nerve blocks in a single patient. So again, that inherently increases the risk because we're doubling the amount of medication we're giving them. And then finally, a new technique that we're doing also too in cardiac, called fascial plane blocks. So they just rely on a volume of local anesthetic spreading in a plane. So again, by default, they require a larger volume of local anesthetic. Therefore, there is an inherent risk for developing LAS. So one of the international registries for regional anesthesia has said that the use of ultrasound reduces the risk of LAS by about 60% compared to some of the more antique peripheral nerve stimulation techniques or landmark techniques that we had used in the past before ultrasound was more common. And then from some adult data or some combined data, they found that LAS is 4 to 5 more times common with peripheral nerve blocks as compared to epidural or caudal blocks. So prevention is key for this. This is an iatrogenic complication, and so one that we need to be very vigilant for. So definitely prevention is key, and that includes everybody that's in the room while we're performing these nerve blocks. So again, as I mentioned, ultrasound guidance is key so that we're able to see exactly where we're injecting the local anesthetic. We will be able to see that it's spreading in the correct plane and in the correct area that we need it to spread in. Going back to the maximum dose that's safe for the patient, usually we're able to get analgesia at doses that are under that maximum dose. So it's recommended that we use the minimum effective dose of local anesthetic rather than going all the way up to that maximum because it may become excessive for the patient. Sometimes we do something called a test dose, so we'll add a low dose of epinephrine, usually 2.5 to 5 mics per cc. To our local anesthetic. So that way, if it is injected intravascularly, we'll either see an increase in the heart rate or we may see an increase in the blood pressure. This can be a little bit less reliable, especially when the patients are under general anesthesia when we are doing the blocks, but it is a level of safety that we can use in order to make our blocks safer. And then finally, you guys may see when we're doing the blocks, we aspirate and inject slowly, aspirate, so we're always making sure we're not having blood return from the catheter or from the needle. And then again, as I mentioned, just vigilance for the early morning signs. If the patient is awake, if they do complain about any of these, paresthesias, weakness, numbness, anything like that, or if they do have a seizure, we need to take that seriously. So the treatment goals if the patient does progress to develop LAS. So initially it's supportive care for the patient if they do have a pulse. So if they're not already under general anesthesia with a breathing tube, we want to make sure that we have adequate oxygenation and ventilation. So that may involve us converting to general anesthesia or just making sure that if the patient is already intubated, we have adequate CO2 and oxygen levels. If the patient does progress to having seizures, we want to treat those because that can prevent the development of any metabolic acidosis, which would worsen this condition. And then, so as I mentioned again, the nervous system toxicity comes first, and then at higher doses or with certain medications, cardiovascular toxicity may arise. So sometimes, again, this ranges all the way from arrhythmias all the way to cardiac arrest. So depending on how the patient presents, we want to make sure that we have adequate perfusion pressure and adequate oxygenation so that the patient will be able to recover from the event. And if they do become pulseless or arrest, we do start ACLS with certain modifications. So we avoid certain medications. We avoid vasopressin, any calcium channel blockers or beta blockers in order to not reduce the patient's heart function. And if we do give doses of epinephrine, we give smaller doses around less than 1 mic per kilogram if the patient does require epinephrine in the setting of ACLS. And then finally, if their patient is presenting with ventricular arrhythmias, we use amiodarone as opposed to lidocaine because we don't want to add any more local anesthetics to the patient. And the next topic I'll talk about when in the setting of LAS is lipid resuscitation therapy. So again, this is used when patients have pretty severe reactions or pretty severe LAS response. So initially, the idea was introduced in 1998, and it was first used clinically in 2006. So there are various mechanisms of action that have been elucidated for intralipid and lipid resuscitation therapy are interchangeable. So first, the medication helps with active redistribution of the local anesthetic away from the heart and brain where it's leading to toxicity, and it redistributes it to the muscles where it can be stored and to the liver where it can be detoxified. There are, from intralipid, it has favorable effects on the heart, so it leads to improved cardiac performance, improved blood pressure and cardiac output so that the patient is able to be supported through the event. And then finally, if the heart does become ischemic, intralipid provides some cardioprotective effects. So here on the right, you can see a picture of the bag. So it comes in 500 cc bags, and it should be available anywhere that we are providing or performing a nerve block. So it's a 20% fat emulsion. Actually looks very similar to propofol. You probably had that thought, but not interchangeable, definitely. So in most of our patients under 70 kilos, we do weight-based dosing. So for the patients that are requiring intralipid because of a severe last reaction, we give them 1.5 cc's per kilo bolus and then follow that with an infusion of 0.25 cc's per kilo per minute. If the patient doesn't respond to the initial bolus, up to 2 more boluses can be given and the infusion can be increased to 0.5 cc's per kilo per minute. And we usually continue this medication until the patient has recovered from the event. And then the maximum recommended dose of intralipid is 12 cc's per kilo. So this is a nice graph that kind of goes through how we should manage these events. So this is, considered an event that is, as serious as a cardiac event or a laryngospasm event. So in these type of settings, it's nice to have checklists, and it's nice to have a way to make sure that you're not missing any sorts of things that may help the patient. So this is a nice graph that may be posted in the OR or places where we're doing nerve blocks, so that if an event like this does happen, we can readily look at this chart. So again, we discontinue any further administration of local anesthetic agents. We support the airway, make sure that we have adequate oxygenation and ventilation. If there are mild symptoms, as I mentioned, they may not require any further treatment other than stopping the local anesthetic and supporting the airway. But if they do develop the severe signs and symptoms, like we mentioned, we treat the cardiovascular side effects and we treat the nervous system side effects. So again, if the patient does have seizures, we give a benzodiazepine or we give propofol if the patient's blood pressure will tolerate. And then, like I mentioned, again, if they do progress all the way to cardiac arrest, we do ACLS or PALS with those modifications. And then finally, this just goes through the lipid emulsion therapy and has the doses here again, so that in an emergency, we're not struggling to find those. And then the only thing that this brings up differently is that if the patient doesn't recover, it's important to consider ECMO because this is a reversible event. So it's important to consider ECMO early if the patient does not respond to intralipid. This is another checklist from ASRA. So ASRA is the American Society for Regional Anesthesia. So it's very similar information, just a different form that can also easily be posted in our ORs or areas where we're performing nerve blocks. And then finally, ASRA has made an app for the smartphones. So it's called the ASRA Last app. So again, this is very good in an emergency. If if one person can pull this up on their phone, we can make sure that we're hitting all these points to adequately resuscitate and save the patient. So. And then finally, this is a nice review slide that I found from one of the references that I found when I was looking this topic up. So it goes over the LAST in children and specifically how it's different than adults. So you can see in the pie chart, so about 50% of the patients have severe enough reactions in children that they require that intralipid. Specifically for our patient population, about a third of these events happen when they're undergoing either penile blocks or caudal blocks. And then about 10% of them happen when we're doing dental procedures, and actually maybe when the proceduralists are the ones injecting the anesthetic, or the local anesthetic, not the anesthesiologist. Again, highlighting the need for ultrasound, about 87% of these cases occurred where the practitioner did not use an ultrasound, so definitely ultrasound is readily available and is needed for these procedures. And then again, 84% of them did not use a test dose with epinephrine to check for intravascular injection before they gave their local anesthetic. Highlighting the young age of the patients, about over half of them were under the age of 3, and then just about 73% of them happen in male patients. But again, we should be vigilant for this in all patient populations. And then finally, highlighting our patient population, about 2/3 of these events happen when the patient's under general anesthesia. So these are my references. Thank you all for your attention. I'd be happy to take any questions.
Anybody have any questions for Dr. Otu? Got a quiet group.
I know.
No questions here, but thank you very much for the presentation.
No problem. Happy to do it.
Hey, Judy, this is Ramon. Can she share that algorithm that she has?
Yes, we'll be posting all this information and sending it out later.
Thank you.
Okay, well, I guess if no questions, then I guess we'll give you guys about 15 minutes back on your day. Dr. Otu, thank you so much for preparing this presentation for us. We are very grateful to you. This was very insightful. And just for everyone's references, this was in conjunction with the malignant hyperthermia presentation that was conducted a few months ago. The intralipid kits are kept with the malignant hyperthermia carts, and in the ORs, they're kept in the pods. So just be sure in your areas, you know where your lipid rescue kits are located.
So Francis has a question. In West Tower, this is kept in pod 1 on the wall right above the MH cart. Francis is asking if it's needed in PACU. Do they use the OR's kit, or is there one in the PACU area?
I think she should check with Ron and ask Ron.
Okay, thank you. And thank you, Judy, for arranging this as well.